You're listening to Mistreated. I'm Kiwanuka. Until recently, menopause was a whisper between friends and trusted ones. In polite company, it was called the change. And if you were going through this change, there was an unspoken secrecy about saying that you were. This stigma still exists in some communities. But in 2024, Oscar-winning actress Halle helped to shatter that silence. While on Capitol Hill, she declared that,
"I'm in menopause!" Okay? The shame has to be taken out of menopause. We have to talk about this very normal part of our life that happens. Our doctors can't even say the word to us, let alone walk us through the journey.
According to the Yale Medical School, menopause is defined by 12 consecutive months without a period, but many people don't recognize that ovarian function begins to decline long before menopause, even in some cases up to 10 years earlier. This transition time is called perimenopause. The menopause transition is more than just hot flashes and forgetfulness. According to The Conversation, an independent online publication from the academic and research community, up to 80% of women develop symptoms linked to falling levels of estrogen, progesterone, and testosterone. Researchers have identified more than 40 possible symptoms. Because estrogen acts on receptors throughout the body, its loss is associated with increased risks of long-term health issues such as osteoporosis, heart disease, diabetes, and mood disorders. While the menopause market is expected to be worth $600 billion by 2030, many going through the transition still lack access to getting the care they need. On today's episode, we speak to Dr. Wendy Wolfman, a pioneer in Canada and an internationally renowned menopause expert. We speak to her about why she became a doctor, the stigma of menopause, and the lack of care for women in health, and about the Center for Mature Women, which is set to open in 2027. The center, she says, is a, quote, dream realized. Dr. Wolfman joins me now. Dr. Wendy Wolfman, thank you so much for taking the time to speak with us. Could you introduce yourself, please?
I'm Wendy Wolfman. I'm director of the Weston Oborn Center for Mature Women's Health and Premature Ovarian Insufficiency. I'm a professor in the Department of Obstetrics and Gynecology and the first Carol Mitchell Chair in Menopause.
You have had a phenomenal career. You're a trailblazer, not just in Canada, but globally. I wanted to talk to you maybe about your journey and how you came to do the work that you are doing right now. What were you taught about women's health when you were growing up?
Not much, but then I came from a family which maybe wasn't the typical family, just like everybody says. My father had polio when he was 28, and he was mobility impaired. And really, I recognized at that time that health was more important than anything else. But I think we concentrated on survival, and my mother did everything with him, never complained, and so she really never talked about those symptoms that may have occurred in the perimenopause. And I have to say that anything that we experienced seemed to pale besides what my father had gone through. So growing up, I don't think we talked at all about that. We got a little bit maybe in school about puberty, nothing about menopause, and it wasn't talked about.
How and why did you become a doctor?
I think that was the major reason is I saw how health affected every aspect of my family's life, socially, economically, how hard they had to work for everything, the discrimination at that time of people who had a visible disability. And I didn't want any other family to have to go through that. And so I also grew up at a time when women were being given privileges that they had never been before. And so also within my family, my father and mother were wonderful parents and really encouraged me in any way they could. And there was no limitation in terms of what I could do as a woman. And then the Canadian education system in Toronto was excellent, and I received a wonderful education in the public school system, and even university. If I got a job in the summer, got scholarships, it wasn't really a burden that I couldn't accomplish. And then being a good student, I got into all the schools I applied for, and so it was really a process. I think that I didn't really define women's health per se until really I got into medical school, trying to decide what I want to do. I got married at a very young age, and my husband was always a support to me. He's also a physician. And I had in undergrad worked with Dr. Wolliver at that time and had done some basic science in the reproductive hormones. And I, being a person who really liked to figure out everything, I really thought that was fascinating.
And is that why you chose obstetrics and gynecology?
Well, I think that was part of it. And then I did a year of internal medicine. After I got married, I got into the University of Toronto, but then I moved to Calgary, graduated from the University of Calgary in medicine, and I did a year of internal medicine because I thought I would do reproductive endocrinology through internal medicine. But then I realized I wasn't really comfortable looking after men. And so I decided to do that through OBGYN. And then you really get seduced for a time with pregnancy, birth. I had quite good manual dexterity, the surgical aspects of gynecology. But then I realized that there was this whole group of women that were not being addressed. It was almost as if women's lives stopped when they became post-reproductive. And when I was at UHN at that time, Toronto, there was a doctor there named Dr. Plunkett, and he was a reproductive endocrinologist, and he had started a very small clinic for aging women. And it was sort of the loser place where OBGYN went for women who were complaining about their hot flashes and their vaginal dryness. In other words, women that were malingering. It was almost attributed to that. And I thought, well, there's got to be more to this than that. And so I started to go to meetings, and I thought, wow, this is amazing. It's fascinating. Look at all the changes that are occurring around menopause.
There's this idea that when you're going through perimenopause, it's like you're complaining, you're just, not tough enough, it's all in your head. So can you take me back to that moment when you realized, wait a minute, there is something here that we should research, and your curiosity?
Well, I think I recognized that there was a huge gap in knowledge as well as care. And I also realized that people were living longer. And we now know that women live up to 40% of their lives after menopause. And also, I think this has been an evolution that, women have gone to the workplace, and we are very vital members of the workforce. And it takes years to develop the skills to get to the top of your fields. And then for women who really have terrible symptoms, they can't function. And so we're losing approximately 10% of women will quit their job because of menopausal symptoms. And for now also, there's fascination with all the changes that are occurring around the perimenopause. In the year before the last menstrual period, there's an acceleration of bone loss. There's changes in your lipids. There's changes in your blood pressure. We're just beginning to understand some of these changes because really women's health research didn't start until the 1990s. That's appalling when you think about it. And so I recognized this gap, and I felt very strongly that it was wrong and that the quality of women's lives was being affected by this lack of knowledge. And women contribute so much to our countries, our families, our partners, our children. We're the backbone of society, and when we can't function, then society doesn't function. Strong women are there for everyone. And then I personally also realized it. If I went to a store, I was ignored because I was older. I finally had earned enough money to buy the products, and I'm being ignored. And I'm thinking to these salespeople, why are you ignoring me? Like, I count too. And so it's a type of discrimination. Even I see it now. Today, I was walking on the hallway, a young man walked past me as if I didn't exist because I'm older. And I think there's that subtle discrimination that's occurring as well.
I'm glad that you talked about how it impacts our overall health, because if you go to a doctor, or if society tells you that once you hit a certain age that you're no longer of value,
Correct.
and then you start to feel different and you have these symptoms, and I don't think anybody wants to come off as I'm complaining, but then you're put in a position to have to advocate for yourself when you're talking to the doctors. And then maybe you start to feel a bit like, okay, it's me, it's my problem, it's my fault.
Correct.
I just need to be mentally stronger.
I absolutely agree with you. And I think when women express opinions strongly, they're interpreted to be angry rather than assertive. And I think that's a problem with our society and how we approach women in general. So I think over my lifetime, I've really seen an evolution in respect for these symptoms. Part of that was the discovery, probably in the early 2000s, of the mechanism for hot flashes. So we now know that the reason people get a hot flash, which is one of the most common symptoms of the menopause, is because there's an inappropriate stimulation of your thermostat in your brain. And being a mammal, you're obligated to keep your temperature within a narrow range. And I learned that in grade 2, that differentiates mammals from other types of animals. And this area of your brain, when you don't have estrogen there, is inappropriately being stimulated, saying, too hot, too hot, too hot. And then your body undergoes physiologic changes to make you cool off by sweating. And that involves changes in your heart rate, changes in your blood vessels. And this is not a trivial event. And if a woman is having like 20 of these a day, and most women, by the way, when you put them in temperature monitors, don't complain of all the changes in temperature that they're having. So you can appreciate how that would affect a woman, her ability to function, and if they're occurring all night, her sleep, which we know is important, and how that impacts daily function. And I think the discovery of this mechanism for physicians really validated these symptoms as not malingering, as being physiologic, and not, I mean, it is in women's heads, but not in the same way that had been attributed before. And so I think the science has improved. I think women are more vociferous, and I think the reevaluation of the Women's Health Initiative, which was that study in 2002 that said that hormone therapy for all women was very dangerous and increased the risk of not only cardiovascular disease but breast cancer, scared physicians as well as women. And there were even lawsuits against physicians for prescribing hormone therapy at that time if women developed breast cancer. So I think we've come a long way. We now know more about hormone therapy. A reevaluation of the WHI shows that actually for women between 50 and 59, who are the group that have the most symptoms, that actually taking hormone therapy is very safe and that the benefits outweigh the risks. But again, it's an individual prescription, has to be determined individually, looking at a woman's complete family history, her own risk factors, and whether she's a good candidate.
I'm so glad you spoke about that, because there's so much confusion about if you can take HRT, and now there's also people are changing the name to menopause
Hormone therapy, and we reserve hormone replacement therapy for women under 40 who develop premature ovarian insufficiency, which we used to think was 1% of the population, but actually is as high as 3.7%. And we know that those women absolutely need to take some form of hormone, or they will have earlier heart disease and earlier bone change, earlier cognitive change, they're at risk for long-term health issues if they not replaced with the hormone that they would have had if they hadn't developed menopause earlier.
The FDA recently took the black box off hormone replacement therapy. Can you clarify on what women should be doing moving forward, obviously after they speak to their practitioner?
So we were very happy that the black box was removed. It scared a lot of women to take hormone therapy, but I think again, it has to be looked at with the type of hormone therapy. So we have vaginal products, which are utilized for symptoms of what we call genitourinary syndrome of menopause, which are the changes that occur in the vagina, the vulva, the supports to the vagina and the bladder, and sexuality based on lack of estrogen. And 50% of women have symptoms within 3 years of menopause, and 70% of women have symptoms by the age of 70. Those estrogen products are 1/1000th the potency of systemic hormone therapy. So it's a teeny tiny bit of estrogen, and it works locally in the vagina. And so there are now multiple studies showing that there are no long-term effects of vaginal estrogens on heart, it's not enough for treatment of symptoms, for risk of breast cancer. It really is a local product working locally. Systemic hormone therapy now had the black box removed in the US as well. For many of us, we think that's good, but we still think that the person or the people who are prescribing that therapy should treat systemic therapy with respect and recognize that the use of hormone therapy is an individual prescription based on the person's family history, their past history, their own personal risk factors, and then the choice of how you decide to prescribe it may be determined by your health risks. I do believe that there should be a menopausal health assessment. We don't even have a fee code for menopause, and this dissuades physicians from spending the amount of time that is necessary to evaluate a menopausal woman. Why do I say that? I say it because I think we can identify the risk factors for women going forward after menopause, around menopause, for many health problems. So, for instance, identifying the person who's at risk for colon cancer, the person who might be more at risk for breast cancer if they have a family history. So identifying, first of all, those genetic risks. Then looking at a woman's history in terms of her lifestyle. We know that there are the American Heart Association 8 healthy heart habits, and that includes normalizing weight, normalizing blood pressure, blood sugar, lipids, Mediterranean diet, regular exercise, not smoking, and sleep. And if you can normalize all those things, then you will potentially have very good cardiovascular health, which is a major killer of women as they get older. So I think reiterating those things and emphasizing them to women is very important. If the woman's having symptoms, like severe symptoms, we know that that puts her more at risk for certain health problems. And we have these good therapies. We have the hormonal therapies. We now have some excellent non-hormonal therapies. And the decision of whether that hormone can be given orally or through the skin, what type of progestin is best to prevent uterine cancer that comes from opposed estrogen given to women who still have a uterus. Those require a little bit of skill.
When people talk about the menopause transition, it's like, oh, it's just a hot flash, like it's something that's cutesy, that's just something that is not.
It's trivialized.
That's the word.
Right. And I think I've explained that it's not trivial, that it actually is a physiologic event. If you look statistically, about 70% of women or 80% have some symptoms. 20% do not. And depending on the study that you read, 20 to 40% of women have at least moderate to severe symptoms. Now, what does a severe symptom mean? It means that the woman has to stop what she's doing. She can't continue on. The symptom is so disruptive for her that she can't carry on her daily life. Some women have mild symptoms or no symptoms, and they don't know what people are talking about.
Can you talk to us about what the Center for Mature Women's Health is?
Well, this has been amazing towards the end of my life and my career to actually have a dream realized. And historically, what happened in about 2010-11, I had a grateful patient who came like an angel and said to me, "What would you like to do and make a difference?" And I said, "Oh, I'd love to have a mature women's health center." And I made a pitch to her and her husband, and they gave us a nice seed for establishing a chair. And then she and I together raised $3 million towards the first clinical chair in mature women's health. Her name was Carol Mitchell. She's still with us, thankfully, and still believed in this, and this has been a goal for her as well. Subsequently, my department chair, Matthew Surmer, recognized this also as something important. And so he became an advocate at the hospital level, approached the board. Maxine Gronowski was head of the board, and the board decided to make this an area of interest for the hospital. They did a worldwide search, and I was chosen as the director of the center. And then what happened is they set a goal of $52 million towards a mature women's health center. And I thought, we're never going to do this. Like, I'll be dead and gone before this is achieved. And lo and behold, due to the wonderful donors from our hospital, as well as our great foundation, and all the people working together, and a lot of work on our part, by the way, within 2 years, we raised $52 million, and no one would have believed it. The last 2 donations are named for the center, the Weston Oborn Center for Mature Women's Health, and we're starting to make the plans to actually see a physical site. And so we've perceived as a center to be really something unique for the world, an example for mature women around the world. Now that I'm on the board of the International Menopause Society and have traveled all around the world and work with these inspiring colleagues, I know that we have one of the best centers currently that I've developed over this time frame. We have a clinic for breast cancer survivors, for women who have graft versus host, patients who have Turner's disease. We have 2,200 patients waiting to see us. And we have multiple days where we see menopausal patients. And how we perceive this clinic is to have 7 clinics of excellence, including menopause, premature ovarian insufficiency. We have the only clinic in Canada for this group of women who no one talks about, and I'd love to speak to you at detail about this. Also, women with abnormal uterine bleeding, that's a very common presenting problem in the perimenopause. A sexuality clinic, also not properly addressed. Urogynecology, the incontinence and bladder issues affect so many women with aging. And then also vulvar disease, which is very common in women, and we have a vulvar expert with us, and also Amanda Selk, who is really nationally known. We're going to have interdisciplinary, and we've already started talking to people within our hospital for osteoporosis, which becomes a problem as women age, psychiatric issues, because we know that that's also a validated menopausal symptoms, is mood change around menopause. And then we also have an association with neurology, because we know cognitive change occurs more often in women. And we want to know, does it really start around menopause? Is this related to hormonal change, to the symptoms of menopause? And these things are being so exciting, really, to be involved with all these initiatives and many others, interdisciplinary partners. And so this is what we hope to achieve. And hopefully we've had a finish date by the end of 2027. So we hope that we'll be able to do that.
I think back to your family from when you were a young child and your father had polio and the discrimination that he faced, and for you to see your dream realized. In your quietest moments, having that dream realized where you are advocating for so many people, what does this mean to you personally?
You know, I thank you for framing it that way, because I don't really think that much about that. I just am sort of a person who goes and does it. But yes, it does give me, I feel fulfilled. I feel honored. I feel that what my mother always wanted and was really imbued in me is to make life a better place. If you're here and you're on this planet, that we all should try and achieve change for the betterment of really humanity. And I do feel that I've made some small contribution, but I thank you for your kind words. Coming from a socialized medical system with all its faults, one of its wonderful things is that we don't look to see what your insurance is when you come in. Everybody is hopefully treated with respect and dignity and equity. And that is a philosophy that I've always had as a physician, and I feel so strongly about it. I know from my parents, when my father got sick, there wasn't socialized medicine at that time. It was very difficult for them. And it's extremely important to me that we maintain that high standard of care, that no woman is turned away. But we need more operating dollars to run the center, and we also need more staff because of the demand.
What changes, improvements are you seeing in how women's health is being taught?
I wish I could say more. That's very frustrating for me, because I think the universities and the medical schools have been slow to catch on to this. And so we have tried to make inroads. We do lectures. We have, for myself, I started a clinical fellowship for obstetricians and gynecologists around 2005, and I've trained probably about 25 clinical fellows in obstetrics and gynecology who are located all around the world and are teaching and providing care for women. And in that way, I think we've made a great contribution. When we look at family practice, we have about 20 family doctors rotate through our center, and we're hoping to have a closer liaison with family practice and to encourage them as leaders in this area. We've trained some who I think are future leaders to really initiate the educational aspects within family practice. We've tried to advocate at the university level, at the residency level. So we've tried, but I think there's so much other curriculum that has to be provided for medical students that we get a very small portion. It's hard for me to make people realize that every woman who has ovaries, who lives long enough, will go through menopause. And I always say that, that's over 50% of the population. And yet, so little of this educational part is given to studying that.
What do you think needs to be done to address the stigma and also this idea that women's health is niche?
Well, I think that there has to be a change in thought. And I can say for myself that after I had children and I'm sort of moving on in my career, and as I said, it's a process. It wasn't all of a sudden for me that I made my biggest contribution after my menopause. And I think if you look around in Canada, many women who are post-reproductive are making huge contributions to our society. And I think we should be recognized for that. And so I think there has to be a shift in thought.
What has been the biggest change and what excites you today about women's health?
Well, I think exactly what we were talking about, that women are being recognized more, that there is less stigma about menopause, that over the last few years there has been more recognition. There's like this menopause explosion, and I think that has good parts and bad parts. And so I think that's the big change I've seen. What excites me personally is the discovery of physiology of aging. And there's some data about aging and age of menopause and genetic aspects to that. I find that, like, the mechanisms, for me, is the exciting part, figuring out why. And why is this happening and what does it mean? And I mean, I wish I could live another 100 years to see all the changes and advances that are going to occur.
We've relied on a lot of studies from the United States. The NIH was the one that mandated that women be included in clinical trials in 1993. And now we're seeing how there's a lack of funding for women's health in the US. Is this an opportunity for Canada maybe to step up in that place?
It worries me greatly that there is lack of funding or funding being removed in the US for scientific studies, because I think we've seen so many huge advances based on that. Yes, it is a big chance for Canada to try and take some of those people from the US and provide them with the opportunity to do research. The CIHR, the Canadian Institute for Health Research, has instituted in the last few years some women's health funding, more than they had before. And so there are competitive grants now in Canada being provided for researchers.
But it's still a small percentage.
It is a small percentage. It's
like 6% or 7%?
Yes, so it's not huge when you're looking at 50% of the population. But yes, there is a change. Things are moving along. And I think we'll get there. I'm optimistic.
Same.
Yeah.
Thank you so much for your time.
Thank you.
Appreciate it.
Thank you.
This was Mistreated. Thanks for listening. You can follow our show wherever you get your podcasts so that you can get notified each time a new episode is available. We would love to hear your feedback. You can write me an email at mistreatedpodcast@tvo.org or reach out to me on my social channels. This week's episode was produced by Chantal Dama, Matthew O'Mara, and me, and edited by Colin Kish. Production support from Jonathan Hallowell and TVO's Digital Media Services team. Laurie Few is the executive producer of Digital. John Ferry is vice president, programming and content. Special thanks to our studio crew here for making the podcast look so great. Thanks for listening.